I think it's been recognised for many years that the immune system plays a role in controlling cancers, and over 100 years ago there were reports of the immune system being used to actually treat cancers. So that history is one of the big things. My work has really revolved around allogeneic hematopoietic stem cell transplantation for patients with leukemia, and some studies that were done about 20-30 years ago now showed that actually T cells in transplant grafts were playing a large role in controlling disease relapse, and so it really stemmed from there, my interest in trying to use T cells to treat cancer. So I work with a group at Fred Hutchinson Cancer Research Centre, and we've done a clinical trial in patients with acute lymphoblastic leukemia, non-Hodgkin's lymphoma and chronic lymphocytic leukemia. Each of these are B-cell malignancies, which mean that they express a molecule called CD19 on their surface, and it's CD19 that we're targeting with the CAR T cells. So what we found is that, and we've published these results previously, but patients with acute lymphoblastic leukemia have a very high complete response rate with clearance of disease from the bone marrow. That's a response rate of over 90%, complete response rate of over 90%. Patients with non-Hodgkin's lymphoma and with chronic lymphocytic leukemia are a little harder to treat, and elimination of lymph node disease in those patients is more difficult than in acute lymphoblastic leukemia, with around about 70% to 80% of patients responding, and complete responses being in approximately 40 to 50%. I think the biggest challenge has been in developing a new therapy and learning how to actually manufacture the cells. We grow the cells in our own laboratories at Fred Hutch. So learning how the logistics of manufacturing the cells and delivering the cells to patients in a timely manner, and working out how that fits in with their other treatments. These therapies have some significant side effects, cytokine release syndrome and neurologic toxicity. In the vast majority of patients, these are completely reversible, but it has taken some time to work out the best and safest ways of giving the T cells. But I think in the last few years we've learned an enormous amount, and I think all the groups around the world that are doing CAR T cell therapy research would probably say the same thing, that we're a lot better at it now than we were when we first started. I think the future of immunotherapy is very bright. I mean, we have at this current point in time checkpoint blockade. This sort of new era of drugs has really come out in the last decade. We're now getting into cellular therapies like CAR T cell therapy that are actually showing pretty significant effects. I think over the next decade, the question is going to be how can we improve the use of these therapies. For example, CAR T cell therapy, we're really only looking at the first generation of effective CAR T cell therapies at the moment. And I think the next group of trials will be looking at strategies to try and improve the way CAR T cells work and the way that they're delivered. We'll be looking at combination therapies of CAR T cells with checkpoint blockade or other drugs. So I think the future is bright, but we have a long way to go to maximise the potential of immunotherapy. So I'm very fortunate in that the institution in which I work is really very much in favour of that style of practice, of actually treating patients and also running the lab research at the same time, combining the two into a translational mechanism. So I think that's one of the huge parts about it, is having institutional support to be able to go out and get grants to do the research. And I also think it's an area that has been struggling for many years, that it's been difficult to get people to do translational research, and there's increasing interest in that now because I think people realise the value of the bench to bedside and then back to the bench method of research.